On the surface, a medical injection appears to be a simple puncture, but at the microscopic level, it requires extreme mechanical precision. The human body does not absorb liquids like a uniform sponge. The skin operates as a highly stratified biological barrier, built from distinct, specialized tissue layers. The exact depth and angle of the needle dictate exactly how the body will process a drug. Missing the target tissue by a few millimeters places the medicine in an entirely different biological environment. Depositing a medication into the wrong layer carries severe clinical stakes. It can trigger excruciating pain, cause localized tissue necrosis, or render a life-saving dose completely ineffective. To bypass the surface barrier safely, clinicians must navigate between two distinct biological zones, the subcutaneous fat and the deep skeletal muscle. Successfully delivering a medication requires matching a specific mechanical approach to the correct biological ecosystem. The subcutaneous layer, or subcutis, is composed largely of adipose tissue. Biologically, this environment is relatively avascular, meaning it contains very few blood vessels. This lack of blood flow makes the fat layer the ideal environment for medications like insulin, which require a slow, steady, and sustained release into the bloodstream. To hit this target without striking the muscle below, the clinician physically pinches the patient's skin, pulling a fold upward to isolate the fatty layer. Depending on adipose tissue depth, the needle enters the fold at a 45 to 90 degree angle, stopping directly inside the fat. As the plunger is depressed, liquid pools at the tip of the needle, slowly diffusing outward into surrounding fat cells. By intentionally keeping the needle away from the body's fast transit circulatory systems, this technique engineers a highly controlled, slow-release drug reservoir. Pushing deeper beneath the fat brings us to the skeletal muscle. This zone is highly vascular, packed with blood vessels, but it actually contains fewer sensory nerves than the surface layers. A rich blood supply combined with a lower nerve density makes the muscle tissue perfect for rapidly absorbing large volumes of liquid, or for processing highly irritating doses that would damage the skin. Injecting deep carries a mechanical risk. Withdrawing the needle straight out leaves a linear track, allowing medication to leak into subcutaneous fat. Clinicians prevent this using the Z-track method. Before insertion, a hand firmly pulls the top skin layers laterally, completely out of alignment. The needle drives in at a perfect 90-degree angle. The clinician then depresses the plunger at a deliberate rate of 10 seconds per milliliter, giving the muscle fibers time to accommodate the incoming volume. Once the dose is fully administered, the needle must stay in place for a mandatory 10 seconds. This strict pause gives the liquid time to begin dispersing into the deep tissue. The needle is finally withdrawn, and the displaced skin is released. As the surface layer snaps back to its normal resting position, the linear wound track is completely severed in half. By manipulating the spatial alignment of tissue layers, the Z-track acts as a mechanical lock, keeping heavy medications securely trapped in their intended biological environment. Achieving this level of clinical precision also requires knowing exactly which outdated practices to abandon. For decades, clinicians routinely pulled back on the syringe plunger before injecting to check for blood, a practice known as aspiration. But as this excerpt from a nursing research review highlights, that habit was driven largely by anecdote and assumption, not hard data. Modern evidence shows routine aspiration is unnecessary. It only prolongs the procedure and increases patient pain. Looking at the clinical guidelines, the consensus is clear. Aspiration is not indicated for subcutaneous injections like insulin, nor for standard vaccines. Another debunked habit is massaging the injection site. Applying physical friction after the needle is removed can disastrously force the carefully sealed medication right back out into unintended tissues. Precision extends to the very beginning of the procedure with the two-needle technique. By swapping the drawing needle for a fresh one before the injection, clinicians ensure absolutely no microscopic medication residue is left on the metal to irritate the skin on the way in. An injection is a masterclass in biomechanics and applied physics. Every fraction of a millimeter and every passing second is a calculated clinical decision that dictates the final therapeutic outcome.